can everyone see the screen? First of all, I would like to mention just the background. There is background information on the websites available. They are displayed here, and maybe feel free to take a look at them. In my talk, I first want to bring the rationale why we did it this way, and in the second part, what exactly we did. And as we heard before, we are more than happy to share with you, and we only can collaborate and achieve the best. In the beginning, it all started out with my fascination for sarcoma surgery as a sarcoma surgeon. And of course, I was challenged by all these cases, just like here, for example, the 83-year-old with a sarcoma of the inguinal region. It's a challenging surgery, and of course, we want to get control of the tumor, but nevertheless preserve the function. We introduce it here, lymph surgery, and I think we really do best what we can do surgically. This is a patient with a chordoma of the entire sacrum undergoing a total sacrectomy. And this is also a patient who underwent a 4/4 amputation for a soft tissue sarcoma of the axilla and plexus with a free fillet flap from the forearm. And this was just my driving force in the beginning. But with time, I realized that it's kind of strange that the principle of sarcoma surgery, they rely independent of the anatomic location, but the technical aspects, they evolve differently. I mean, a surgeon of the toe is not the same surgeon as of the liver. And there are different techniques, and somehow, although the biological principles are the same, it becomes clear that one single surgeon does not cover all aspects. And for this, we cannot achieve the best for the patient. Further, there's always a balance between achieving tumor control and organ function. And it becomes obvious that the surgeon cannot decide on himself. It's with the patient, with the entire environment. So in other words, it has become clear over the years that we can achieve the best results for surgery if we collaborate for complex cases, just like here in the plexus region, where we reunited all, let's say, the disciplines at the table. But of course, this is not only just applicable to the surgery, it's applicable to all disciplines. So what applies to surgery, it also applies to pathology, radiology, medical oncology, radiation oncology. So it becomes clear to achieve an optimal result for the patient, well, there needs to be a collaboration on one platform. It cannot be that we act based on the discipline. We have to act problem focused. So it cannot be that each discipline builds its tower. They need to communicate with them, again, because it's the patient, it's not about the discipline. So the goal has to be that we act and share as one team. Taking a step back, how is healthcare organized? And of course, I'm speaking mainly about Switzerland. It becomes clear that, mainly we are in a silo organization. Every institution works by itself, and collaboration is rather difficult. So we have to change our thinking. Let's call it ecosystem. The question is now, how can we do this? I mean, we need to design a system, or that the system only produces what it's designed for. So it becomes clear that we have to move from a closed silo legacy system to open network. But for this purpose, we have to define the focus. Basically, it's clear it's a patient, but we need to build the system around the patient. And with what aim? The value proposition is quality. So a system, an ecosystem, which is focused on the patient and with the aim to improve quality. So in reality, that means that we need to move from processes to outcome, from from volume to value, from quantity to quality, and from eminence to evidence. So a novel ecosystem needs to define the value offerings. And to achieve these value offerings, there's the entire, all the pieces needs to fit together. It's comparable to a tree. We are interested, if we are hungry, in a good apple. But the apple can only be good and tasty if the environment is appropriate, if the roots are good, and there's a fertile ground and strong branches. And so all parameters need to contribute. So that then gives us the question, how can we produce, or how can we design a system which produces quality? There is Michael Porter, a professor of Harvard in Boston, who defined the shared value as quality dividing over the total patient costs. Of course, the question is, what is quality and what are costs? But the bottom line is how we only can achieve this with data. And if we look at healthcare data just in general, we can describe it as data vortex. It's just like a hurricane, and we have no really overview. If we look at the productivity of medical data, we see that in the latest years, there's a huge increase of medical data. But even more importantly, the huge increase is attributed to unstructured data, meaning we cannot retrieve data and search for something. So obviously, this is a huge problem, and this needs to be addressed. So why? It is clear, at least to me, that if we don't embrace data-driven medicine, we will get lost. But more so, we may go the danger that we endanger people's lives. So what do I mean with this? So today we share, or we just assess our numbers, and we satisfy ourselves with descriptive analytics. But we need to move on, meaning, we need to be able to perform a predictive analytics or maybe even a preemptive analytics. So the bottom line question in the end is, how do we create a shared value from data? So that is the introduction for what we did. And that's why for the Swiss Sarcoma Network, we have our mission, our North Star, which is to create a novel healthcare ecosystem for patient sarcoma care based on quality and ethical transparency. The strategy is we want to define, to assess, and to visualize quality in sarcoma healthcare. Of course, it did not hurt that the Swiss government decided to introduce a new law this year that quality needs to be assessed. But even doing so, they did not define what type of quality it looks like. So in December 18, we founded the Swiss Sarcoma Network as a foundation. Then we had several milestones, but in December 19th, we could introduce this prospective registry. And of course, we invested into education. That was the webinar last year, which was started. And now we are able to also perform a real-time interactive outcome analytics, which I will share with you within shortly. So from the organizational standpoint, we have three main columns, which on the one hand is the tumor board. We call it the Swiss Sarcoma Board. And at the same time, its associated registry and the so-called Sarcoma Academy, which includes teaching, education, and research. The purpose for this is to perform predictive, hopefully prescriptive, and even preemptive outcome analytics in the future. So all is under the auspices of quality indicator, that's the North Star. And on the other hand, we have 4 international top experts who shadow the process and advise us in doing so. The multidisciplinary teams are organized in so-called integrated practice units. These are units of disciplines which include all disciplines under one roof in one institution where they, let's say, collaborate together. And We have it done such that it is, let's say, an IPU belongs to the surgical department as well as to the tumor center to also in the institution represent all disciplines. And there are, and hopefully will be, even more IPUs all over Switzerland, and they are connected through this network. And the point in the end is, you know, this basic structure can be extrapolated also to different countries, of course, such as Egypt. As said before, we have our 4 advisory board members, and they are eminent people and representatives of the World Sarcoma Network. We are also part of the CELNET, the Sarcoma European Latin American Network, which also has, let's say, shares the same goals. And the vision is that we are able to evolve a global sarcoma quality network. And of course, it would be fantastic if we could do that together with your country. So as said, the mission of the Swiss Sarcoma Network is to assess the quality of patient sarcoma care. And for this, we need to assess physician-defined quality indicators with real-time assessment. The objectives is we need to be able to assess all patient-related numbers. We need to establish a quality management system. And the goal is, because we cannot force anyone to take part in this endeavor, but the goal is that everyone can participate who commits and who shares the data. I think a key component of the whole setup is that the multidisciplinary tumor board, the sarcoma board, is intimately related with the registry of our foundation. So that means that, you know, if you announce a patient to the tumor board, all this information is automatically or similarly saved in the registry. So this all goes in parallel along. And as such, we have at the end of each tumor board, we have all data completed. And then, you know, we can perform the analysis. So we do not have a data analyst who needs to, you know, run after the numbers later. So that's the goal. And as such, we are able to run a transdisciplinary real-world data platform. We see some 1,000 patients a year. Of course, not all are sarcomas. There are also simulators and suspicions of sarcomas. And the strategy behind the registry is twofold. There are physician-based parameters and patient-related parameters. The first includes, of course, all WHO diagnoses, all anatomic locations which are coded, meaning in terms of structured data so that they can be retrieved, types of resections and type of reconstructions. All is stored well, either locally at the institution, if this is preferred, or you can also use a cloud service. The front end is, or will be soon be ready to be used over the RedCap, and that's the entry point of the front end. And the other part that you see will be the data analytics, which I will share you too. But this, of course, has to be individually defined with each institution. Then, of course, if you have the setup, you need to define quality. What is quality? And of course, we have set together a few days. We just sat into a hotel room and said, among a small group, what is quality? How do we define quality? And of course, this went back and forth, but we came up with basically 6 main fields. One field is sarcoma board management. One is the workup. One is therapy, outcome, complexity of sarcoma therapy, and probes and primes. And you can imagine that each of these parameters, let's say, adds up to a score, and there's a total score for, let's say, a multidisciplinary team within the context which can be internationally compared. But each of these parameters is again has sub-parameters. So this is shown here. These are the parameters for workup. This is for the sarcoma board meeting. This is for therapy. And in the end, we have close to 80 parameters. So the point is, of course, at first sight, this is not possible. How can you assess 80 parameters at the same time? To do so, it is, of course, first we have to reassure the quality. And the quality is provided, let's say, here through an interactive website, which we call missingness of data. So we know now, all in real time based on the registry data, that, for example, for institution 1, there are right now, as of yesterday evening, there were these missing data which needs to be filled. So everyone knows, because, for example, here's a code of the physician who entered the data. So he can now be reminded that this parameter is still missing. So this is a very nice tool that just to keep track and to efficiently know what's missing. And if something is missing, you just can fill it in. This is now basically the heart. These are the quality indicators of sarcoma care analyzed on the interactive website. And just to show you this in real time, I take the time to launch the website. You can see it here. So you have here the tabs for the different quality indicators. For example, I just choose this one. So this is a quality indicator of the sarcoma board meeting, and you can see here that we know now that from just this year we have so many deep soft tissue tumors. We have so many bone and superficial tumors. We have here the paragraph, let's say, per month. And the nice thing is, you can switch between patient. Also, this is just the number of patients, and this is the number of presentations, which does not necessarily need to be the same. You can here switch, let's say, the year. This is just now this year, but you can choose this month, or you can include the previous year. You can see here, for example, well, I only want to see the malignant patients, and then it instantly adapts. And then you can see here, how many patients you had when. We will add here also the raw data, so that you can just by a click go back and into the registry and see which patients you are interested. You can also here choose from the institutions. So every institution has a number, and then you can, for example, see, I take here institution 4, and you see how many sarcoma patients this institution treated just this year. And you can do this for, let's say, the anatomic location, and you can do this for the diagnosis. So this gives you a whole, let's say, all at once, transparent, real-time analysis of what's going on in the registry or in the treatment of your NDT. Here I have assembled the prompts. We are also in process of these prompts. We have also here a website created, so you can see here the different prompts, and then the patient can fill them in. In the end, you can here send it off, and it's directly saved in the registry, and then you can compare it with all other data, and you do not need to transfer any paper forms or whatsoever. The goal is now to add this together, and based on what type of treatment and when it started, that the patient receives automatically a QR code as shown here. So the patient can fill that in at home before his outpatient visit, and then it's directly related in the registry. So what do we do with the prompts? We call it cockpit. If you take again the biopsies here, you have a cockpit, also a real-time interactive website where you can see the different questions and how patients answered, let's say, overall. For example, this question here, were you well informed about the reason of the biopsy? Yes, I want to know that I want the patient to be greatly informed. So if this would be differently, if there was a 2 or a 3, I would know that I need to improve something. So this is something we are continuously working and improving, but just to share, let's say, a glimpse of where we are right now. So the whole point in the end is we have the clinical metrics, we have the PROMs and the PREMs, but what we want include in the next step is, of course, all the cost tags to all structured data we have included in the registry. So in the end, we really can perform predictive, prescriptive analytics. That's the goal. So how does this all connect together? You have your computer. The patient has ideally an app, a Sarcoma app, where he has access to all information from the registry, that he gets all the appointments, that he can fill in the prompts, and then because this is connected, you're always aware what's going on there. I think this is the first step toward telemedicine. And the third big part is the Sarcoma Academy. As said, we are focusing on education and on research. And there are the webinars. We started over a year ago, as said. The next one is the 4th of November. Professor Lessen from Paris, he is talking about all the news from ASCO and ESMO this year. So this will be rather exciting and maybe safe to visit these meetings. So you have just an overview from a top expert over what was presented this year at the top meetings. Of course, everyone is welcome, just register. We have in parallel also developed a forum, meaning you can post cases here, for example, with a PowerPoint or just a link, and then the entire community can answer and give opinions. And so like this, you can share difficult situations, decision makings with the community in the end worldwide. The same thing is also for orthopedic oncology. We have here also this type of forum, the IVINS forum. We had the first meeting on August 23rd, and this was a success in that terms that we said we want to continue. On January 15th, we have a next meeting, and there we will share all cases of scapular resections and reconstructions. And the goal is that you really can pinpoint, the pearls of these type of surgeries. But of course, future has to tell whether this will be attractive or not. But as of now, I'm thrilled to continue this. Then, of course, with this type of data, we can do things which were not yet possible. For example, we have here already put together a sarcoma surgery complexity score. We have defined what is complex and not for each different part. And then we have received, let's say, a result where we can say, okay, this is a complex sarcoma surgery. This is a simple sarcoma surgery. And I think this will be important also, where should, what type of surgery be performed. And also, I think for billing purposes, this will be interesting. We are working also on a quality score, but of course, the possibilities are unlimited. The real goal, of course, is that with our quality data, it's a huge fundus, right? So we take this data, we apply algorithms, we define predictors, and as such, we will be able to come up with deep learning algorithms with a model, which can be applied for every future patient, meaning we can then indeed provide individualized prognosis for each patient based on the multitude of parameters which we know based on our patients. So I envision that with this setup, we have to be able to really perform precision medicine, to get out all of the potential that data provide if we assess them in a structured way. Wrapping up my talk here, I think we're in the midst of the fourth industrial revolution. It's not about the incremental change of one big finding. It's a confluence of many quantum steps. And I think we have to be aware of this. And for this, we need to align our data and we need to collaborate across the borders, across the continents. And I am completely, thrilled to go this way. I want to conclude by saying that we need to open up to leave the silo thinking. We have to act together in a quality-oriented way and to deliver patient-focused, transparent, added value and coordination with all stakeholders. With this, I really would like to thank you for your attention, and I'm more than happy to take any question from you, also later by email, whatever suits you best. And of course, I would be thrilled to contribute the Egyptian sarcoma network as much as I can. Please just let me know.
Thank you, Professor Fox, for the interesting subject. And actually, it's I was talking with Dr. Wael from Al-Azhar, and we are talking about in such low number of sarcoma cases. I mean, there is no way to build up experience other than having this network. My question actually is about the platform for this network. I mean, you have a fund for this network actually for to build up this platform. I mean, how? I mean, if in Egypt, I mean, if we would like to build up a similar network here in Egypt, I mean, what is a fund from pharmaceuticals or a fund from the Ministry of Health? I mean, how to have such a platform, such the one you have in Switzerland?
I think that's a very key question, very important, and I think that's a needle ear. I failed also in the past, and this is a question which is really important. In this case, we solved it such that to involve all stakeholders, we determined that, let's say, the members of the network of this foundation is not a specific person, is a respective institution. You know, in CTA, CTB, CTC, the institution is the member, and as such, you have, let's say, the administrative director, you have the medical director, and the sarcoma representative. And there needs to be a commitment that they want to do that. And of course, there's a membership fee. And as of now, we finance all through this membership fee. But it's needless to say, the vast majority of all this digital capacities, that's all, let's say, hobby by a few people who are really, spending all their free time into that. But my vision is, in the end, that because we have such data, this then will be attractive, for example, as you said, for pharma companies. And through this, we will be able to fund even more. I mean, also attract the international community. And personally, I think it's the same thing as with the data for our patients. If we have this set up, and if we can bring this to conclusion, what I just mentioned now, there is, let's say, maybe a small membership fee in the end that everyone contributes, but then we all can afford it, because we only need to do it once. Right? Our goal is not to earn money with as much as possible with what we have. Our goal is to improve the quality. For this, we need the platform.
Thank you very much. And I will, if any questions from the floor for Professor Focus.
Yes, I will add some information that we, as Professor Ahmed Ramadan, is creating Egyptian Sarcoma Foundation to help us for creating this network. But we need first to remove the barriers through the institute to feel free to share this data and to avoid to keeping the data for itself. If we reach this concept and we share our vision, I think we can successful more to create a well-developed Egyptian sarcoma network.
This would be great to have this foundation, and I encourage this foundation. And actually, in Tanta, I mean, we would like to join this foundation to share the data for our sarcoma patients. I mean, like I said, I mean, there is no way for us to have a good experience. I mean, with such rare cases. Yes. Unless we combine all the experience from all institutions.
Yes.
So that's very important.
Thank you.
Thank you very much. Any questions from the floor?
Maybe one comment, if I am allowed to do that. Don't be discouraged. The main philosophy has to be unite the willing. You should not be angry about those who do not want to commit. Be happy with those who do commit, and together you are stronger. So this is how it starts.
Okay, thanks a lot for this nice presentation. We'll move to the second talk. The topic of the talk is radiotherapy indication in soft tissue sarcomas. It will be presented by Professor Dr. Studer. Please, Dr. Studer.
Do you hear me?
Yes.
Good afternoon, dear colleagues. Do you hear me?
Yes.
Excellent.
Yes.
So, thanks a lot very much for giving us the chance to participate in your conference. Thanks very much to Mr. Hassan. So, my talk will probably be quite simple, easier than Walter Fox ones. So, articulation in extremity soft tissue sarcoma. So, I'm going to share with you some thoughts, some facts regarding rationale for radiation therapy, needs for rational therapy decision in sarcoma, indications for radiation, and the treatment sequence. Rationale for RT. Decades ago, the main approach to treat sarcoma, as you may know, was basically amputation. Then the thought came up, is that really indicated, is that needed? And there was a trial testing amputation versus wide local excision and RT. And see what came up, disease-free survival was identical. So this data was won from a Prospective Trial 40 years ago. So that was basically the entry of RT into the field of sarcoma. Next thought was maybe excision only is enough, and they did the trial surgery only versus post-op radiation. Look at that. The lower one, the lower line is just surgery, the upper line is adding radiation. So this data is 25 years ago. They thought also about, is it needed, is it required to add radiation in low-grade sarcoma? And you can see on your left, there is a curve with all patients, in the middle, high-grade patients, radiation to all kind of grades. This is an analysis with only G1 sarcoma patients with tumors bigger than 5 centimeters. And you see surgery only without radiation ends up in about 30% of the recurrence rate. When we add radiation, it's about 5%. So real convincing data. What about radiation in unresected sarcoma? Means in patients unable or unwilling to get operation. So this data is about 20 years ago by Herman Soot, and he analyzed about 112 patients with mainly big tumors, more than 5 centimeters in 80%, and he found when we are faced with tumors up to about 5 centimeters, the local cure rate is about 50% when we use radiation only. For bigger sized tumors, it's getting different. Needs for RT decision. What do we need as radiation oncologists to decide if radiation is an option, is an indication at all? So we need a histopathological proper diagnosis. We need initial DNM, of course. We need a recent pre-op MR, giving us information about the tumor size, the edema extension, and the tumor localization, means epifacial, subfacial. And nowadays, as you hear now, we need really specific sarcoma conference with a treatment recommendation on an interdisciplinary basis. What is NCCN saying us? So that's important, essential. Prior to the initiation of therapy, it is highly recommended that all patients be evaluated and managed by a multidisciplinary team with experience and expertise in sarcoma. Next point, adequate imaging. Next point, careful planned core, needle or incisional biopsy. Next point, place your biopsy along future resection axis. So to my opinion, these are really 4 key points. What if not? So when we do not multidisciplinarily discuss cases pre-therapy, so we end up in an unstructured treatment plan, suboptimal procedures, and whoops lesions. As you may know, so-called whoops lesion means it's an unexpected sarcoma diagnosis, so surgery not on the oncological aspects performed, no prior biopsy, plus minus no prior imaging. Disaster, not good. So what when we do not have proper MR imaging of the tumor region, we end up in an inadequate TN classification. Incorrect biopsies translate into suboptimal samples, and wrong anatomical way biopsies translate into unnecessary tissue contamination. So what about T? We have here the 8th edition, T staging for sarcoma, and they divide into tumors up to 5 centimeters, 5 to 10, 10 to 15, and 15 plus. So that's, well, for radiation oncologists, it's not so informative, let's say. The 7th edition was a little bit more informative for us, as mentioning the localization of the tumor as well, superficial or deeply located. That's an important information for radiation oncologists. From our side, we really like this vulnerable staging, mentioning size and localization. Anyways, indication for RT. So it's really simple. When you have a T1 up to 5 centimeters, epifacially located, low grade, and your surgeon tells you no radical surgery feasible, we don't need any radiation, none. surgeon opinion. Surgeon's opinion to the case is required. To summarize, it's very simple. Most situations should be at least think about radiation. Sequence of RT, that's NCCN guideline. And in red you see, based on the pros and cons of pre-op versus post-op radiation, the panel has expressed a channel preference for pre-operative radiation. So that is based mainly on this Canadian trial 20 years ago by Sullivan and his group. They did a randomized prospective trial with one arm pre-op radiation, the other one on post-op radiation. And what did they find? They saw for pre-op radiation, we need lower dose, smaller volumes, same tumor effect, less late-term effect, shorter treatment time for patient, and somewhat more wound complications, but they are transient. So to give you an idea, this data showed post-op radiation, we have about 17% wound complication, pre-op radiation translates into about 35%. In our cohort with Bruno as a main surgeon, we see about 7% wound complication. What about post-op radiation? So that should be seen in parentheses nowadays. There's still sometimes a situation we have to think about. For example, underestimated tumor, unexpected R1 or 2, or we are faced with a whoops situation, or we are center with intraoperative radiation therapy option. We don't have it. And intraoperative radiation it's unclear, its value is unclear. So do not be sad when you not have this option. RT volume is a very big issue for radiation oncologists. There's a very nice Rgo3 trial 6 years ago. They tried to a little bit shrink the huge treatment volumes we used to perform. So decades ago, we thought we have to cover the entire compartment. Then we detected, okay, it's not necessary to treat the irradiated entire compartment. We may just give large margins. And with this trial, we know when we have 8-centimeter tumors or bigger tumors and G2 to 3 tumors, we should add about 3.5 centimeters in the longitudinal axis as treatment volume margin and about 2 centimeters in the radial direction. For tumors smaller and G1, we can be a little bit tighter. Another RT volume issue is the perifocal edema. That's an important topic. RTUG tells us the clinical target volume has to be covering the suspicious edema. What do we mean by edema? You see here, the yellow structure is all edema. It's basically even bigger in this case as the tumor itself. And why do we need to cover edema? That's another Canadian paper telling us, okay, edema is contaminated, is affected with microscopic disease. So we have to cover with this edema zone. Leads us to the aim of RT. The real aim of curative added RT is to improve local control by sterilizing the environment, sterilizing the microscopic disease around the visible microscopic tumor. We do not have any impact on overall survival. We just have impact on local control. Another aim may be, but it's not necessary, sometimes we see some tumor shrinkage. And the real aim is to avoid amputation. Some words to shrinkage. We have some radiological response to RT in sarcoma. Depends on the grading somewhat. Low grade non-myxoid, median shrinkage about 14%. It's basically nothing. Myxoid, median shrinkage about 50%. That's reasonable. And high grade tumors used to not shrink at all. The important thing for radiation oncologists and also surgeons, inform your patient, because patients think, oh, well, I'm getting radiation treatment, great, my tumor will shrink. And then they see nothing happens, and they get disappointed and desperate. So that's not necessary. Just tell your patient, relax, we do not expect this tumor to shrink. Histopathological response, there's a range from 0 response visible to 100% necrosis. So basically both radiological response, histopathological response are both no prognostic parameters. It's not a prognostic thing, so just keep relaxed. Pre-operative radiation dose in sarcoma. So the NCCN say 50 gray in 25 fractions over 5 weeks. That's the current standard. Right. So this list shows you the available prospective trials working with normal-vaccinated pre-operative radiation in sarcoma. Local control about 88 to 100%. This list shows you mild hypovaccination. Hypovaccination means we give a little bit more dose per session and less sessions. That's quite nice for patients. So mild hypovaccination means 10 times 3, 10 times 3.5, things like that. The local control rate is quite similar to normal vaccinated schedules. Next step, extremely hypovaccinated schedules. This list shows you examples with 5 fractions only, but 5 or 6 or 7 gray per session. So that's quite a lot. That's 5 fraction regimens. So the current standard is still 50 gray in 25. However, the trend is clearly going in this direction. Less sessions, higher dose per session. This 5 fraction regimen is very, very handy and safe, for example, in the pandemic situation right now. So at Lucerne, in our center, we work with this 5 fraction regimen since 1.5 years, since pandemic. But again, to mention, it's not standard, but we know based on this data, it's feasible, it's possible, it works. So in order to give you some kind of recovery from my texting, I want to show you some typical sarcoma examples. So the pink line, the inside pink line shows you the gross tumor volume, the visible macroscopic tumor, and the red line around shows you our intended radiation dose volume. And here you see the isodoses, those lines, and here that's a nice kind of making radiation visible, color wash picture. Red means high dose, green means intermediate dose, low is in blue, low dose. Another example, typical huge tumor, pounds and pounds of tumor. Another example. So lessons learned from sarcoma with no metastasis, never give up. I mean, it's amazing to be able to cure such huge tumors. To summarize, indications for preoperative radiation: large tumors bigger than 5 centimeters, and or deeply located tumors, tumors close to or invading neurovascular bundle, and surgeon's opinion. When the surgeon thinks, maybe post-op RT is maybe required, then go for pre-operates. It's better for your patients. So I really hope this may mean many, many thanks.
Thank you, Professor Studer, for the presentation. And I have one question regarding the preoperative radiation in sarcoma. So you mentioned that we have a response rate of almost 50% in the myxoid sarcoma. So if we have this 50% response in the tumor size, so do we have to put like a clip or something like this in the tumor? So at the time of surgery, we would go for the pre-treatment tumor volume or the post-treatment tumor volume?
That's basically, thank you very much for your question. That's basically a surgical question, what I can answer. We used to rescan patients after radiation with a new MR. So the surgeon knows what he will face in the operation room. And usually the surgeon is just orienting according to the residual gross tumor volume.
So we will go to remove just the residual tumor volume.
Right. So
okay.
The residual volume.
Okay.
Yeah. And shrinkage is of no prognostic meaning, but of course, when it's 50%, it's better for the surgeon. So more space, maybe easier to
okay.
Protect around the surgery, around the tissue. Yeah.
Okay.
And
So.
it's nice for the patient, of course.
Okay, so my second question is about the tumor, the dermatofibrosarcoma. I mean, do you have an indication for post-operative radiation for such tumor, the dermatofibrosarcoma tumor, or would you consider this for the superficial tumors with no indication of post-operative radiation?
I again would go after the hard facts of the surgery. Kind of what says the histopathologist, what do we find regarding margins, what is the surgeon commenting on histopathological margins. So sometimes the surgeon says, yeah, it's clear, but the next quarter was a bone, so the margin is small and things like that.
Okay, thank you.
Kind of interdisciplinary discussion.
Okay, thank you very much.
Thanks a lot for this very nice presentation. I have one question for you. In real life, do you usually offer preoperative radiotherapy for most of the patient? And what is your current approach for preoperative? Here in Egypt, actually, I think we didn't start to offer most of our patients the preoperative radiation therapy. What do you know about your experience in Swiss? How often you prescribe pre-op radiation?
We do in each case, we think surgery may not be enough. So we do it very often. So in all tumors bigger than 5 centimeters, in all deeply located tumors, yeah.
So it's the common practice now, likely. You are likely prescribed pre-op.
Excuse me?
You are currently likely, for most of the patient, you are likely prescribed pre-op radiation.
Yeah.
Yeah, okay.
Yeah, I think so. Yeah.
Okay.
And as I mentioned, at the moment we go for the 5-session regimen. That's not standard yet, but we in Switzerland we have quite a predominant pandemic situation. We have to protect our patients. We shouldn't bring them too often into hospital, so it's kind of really safe and quite handy for all times. But it's not
Okay. And when you like plan for surgery after the short course, just shortly, 1 week or more?
Yeah, right. That's right.
1 week after.
For deciding that, you need a reasonable surgeon who is open and ready to co-work with you, of course. That's not radiation oncologists alone decision.
Yeah, yeah.
And Bruno Fuchs and myself, we are in tight contact and we are kind of friends. So we discussed that and we decided, yeah, let's go for that. We have data with immediate surgery, means a couple of days after radiation completion, we can go for surgery. Or we have also data of centers they just wait. And in the pandemic situation, it was quite pragmatic and handy to just jump on the next operation room slot available. So we were kind of, okay, when it's tomorrow, then let's take the tomorrow slot. And when it's in 3 weeks, okay, then let's take the 3 weeks slot.
Okay, thanks a lot for you.
And so far, we didn't, Bruno Fuchs is not describing any subjectively, any differences as compared to the 5-week pre-operation schedule. So the surgeon seems not to feel that in the tissue. And so far, we just recently analyzed our wound complication rate in about 25 fraction patients, and it's unspectacular. So basically no wound complication.
Thanks a lot for you. Any questions?
Professor Studer, sorry? I can just ask you a question about a special entity, which is retroperitoneal sarcomas. So as you mentioned in your presentation, you sometimes see like the whoops surgery. I mean, so you get the pathological surprise of retroperitoneal sarcomas. So do you often prescribe post-operative radiation to these patients?
No. In most situations, when we think, okay, this patient needs some more treatment, then we discuss to handle the situation as it would be primary. So we often in whoops lesions go for pre-op radiation, including all the region the former surgeon may have touched, and then for real oncological surgery.
Okay, and just my second question is the role of palliative radiotherapy in maybe in cases with oligometastatic disease, or you sometimes go for definitive radiotherapy in these cases. Thank you.
We often see meds, of course, and mostly in lung, as you know. So we then think about, when the lesions are smaller and not too many, about stereotactic radiosurgery.
Thank you, Professor Studer. Any questions? Any questions from the floor? Okay, go ahead. We have one more question, Professor Studer.
Thank you so much for your fruitful lecture. My question is about hypofractionated regimen. Is it applied on pre-operative or post-operative radiation, or pre-operative only? My second question, what about toxicity profile? Is it equivalent to conventional fractionation? Thank you.
Thank you. It's only for pre-op radiation. I personally do not know any post-op hypervaccinated schedules in sarcoma. So just for pre-op. And regarding tolerance, we do not see any difference. As basically, that's a radiobiological kind of calculation. 5 times 5 is basically a little less doses than the 50 in 25 fractions. But because we give them in 1 week, it's biologically more effective. advantages so far.
Thanks a lot, Professor Studer, for the nice discussion and lecture. And we will move to the next speaker.
Professor Ahmed Ramadan, in Mansoura University. He will present us a case for discussion. He will join virtually. Wa alaikum salam.
Dear colleague, I'm happy to be with you today. We will discuss a case of advanced clear cell sarcoma. Nice case, clear. This a female patient, 25 years old, premenopausal, single, with no relevant medical or family history. She had a past history of left inguinal swelling 15 years ago without histopathological examination. 9 months ago, she noticed a left inguinal swelling again. By examination, she had a mass of the left inguinal region, 6 by 6 centimeters, not mobile, and no palpable upper cervical axillary lymph nodes. She had a core needle biopsy from this suspicious inguinal mass, which revealed diffuse proliferation of rounded cells with ill-defined cell borders, and nuclei are rounded, hyperchromatic, scanty with mesopenic to clear cytoplasm. She has also a brown granular pigment is seen and fusile necrosis. Immunohistochemistry markers reveal strong diffuse positive cytoplasmic reaction to HEMB45 and also for S100, but focal positive for inhibin and negative for Milan A and cytokeratin phytoprotein glypican 3. So the diagnosis was based on this immunohistochemistry markers to be a clear cell sarcoma or the old name melanoma of Sotos. This patient has a staging CT which revealed heterogeneously enhancing left inguinal soft tissue mass about 5 by 6 by 8 centimeters, encasing the left common femoral vessels about 180 degrees with enlarged left inguinal lymph nodes. A post-contrast MRI on the left side revealed the same situation, with contacting only without invasion of the left common femoral vessels posteriorly. CT angio was also done to inform about the vascular invasion, and also the same as demonstrated in the MRI and CT. And we can see the MRI pictures pre-op, where we can see this lobulated, well-encapsulated mass in the left inguinal region. This is the CT, where we can see the mass also reaching to the skin, and on this we can see also it is encasing the femoral vessels without direct infiltration. During examination of the patients, because this melanoma was suspected differential diagnosis, she had a suspected bulbar lesion, and a biopsy was taken, which was free skin tissue with no evidence of malignancy. Then she subjected for a wide local excision surgery, and the operative report indicated that this patient removed, and the surgeon removed the mass from the inguinal ligaments surrounding the muscles and the femoral vessels, with contacting with the vessels anteriorly without infiltration but encasement alone. And the mass was also partially encasing the common femoral vessels and entangling the saphenofemoral junction and some branches of the femoral nerve. Ligation and excision of part of subvenous vein was done, and margins were sent for frozen section, which were free. The histopathological diagnosis after surgery revealed a mass of 6 by 4 by 5 centimeters with necrotic areas, and the microscopic described the same as core needle enhancing fluid collection and the left inguinal region. From your opinion, this is chairpersons and for our guest speakers, what do you recommend as an adjuvant treatment for this patient at this stage?
Dr. Ahmed, thank you for the case presentation, and I would suggest post-op radiation in view of clear metastatic workup. Any other opinions from the floor? Okay, Dr. Ahmed.
Thank you. We already discussed the case during the MDT in our institution and also in the Egyptian tumor board for sarcoma, which we started 5 months ago. And our decision was the same as yours, to give adjuvant radiotherapy to the tumor with 60 gray over 30 fractions in 2 phases, with a small volume in the second phase. But unfortunately, the patient was delayed to receive radiotherapy at the preferred time. But during the radiotherapy sessions, she had an acute back pain of the dorsal vertebrae. MRI dorsal spine with contrast reduced the height and anterior wedging of the fourth dorsal vertebra with retrobulging. And there is a change in the bone marrow of this vertebra with low signal intensity in T1 and high in T2 and T2. And after injection of the IV contrast, there is significant contrast enhancement. Also, there was a small enhancing paraspinal and intraspinal soft tissue mass with compression of the ventral aspect of the cord and both related nerve roots. Also, there was a bone marrow change at number 1 and number 2 suspected to have metastatic disease. The patient has a new staging CT, neck, chest, abdomen, pelvis, which confirmed there is no other new events other than newly developed left lower pulmonary dues. After discussion with the radiologist, he said that it is significant, but he cannot say it is a metastatic, and we can go for follow-up for this lesion. But after 2 months repeating the scan, the patient received palliative radiotherapy to the bone metastasis to improve the pain. Also, we tried to have a neurosurgical consultation for decompression of the cord, but already they declined this intervention for this small intraspinal mass. So, repetition of the CT revealed that there is a progression of the bilateral pulmonary dues, and largest now is 3 by 2.5 centimeters, as you can see in the right lung. And also there is a left iliac small lymph nodes. So my question now, we have a patient with rapidly progressing or rapidly relapsing clear cell sarcoma, and we have a widespread disease in the bone and the lungs and some lymph nodes. What is the best systemic treatment for her now?
Would go for systemic chemotherapy as soon as possible. The clear cell sarcoma, I mean, there is, we could start with chemo, and there is many protocols. I mean, you could start with holoxan, adriamycin, for example. Any suggestions from the floor? Okay, Dr. Ahmed.
How do you explain this rapid and aggressive pattern of relapse?
You could refer back to the pathology. So the pathology would explain the aggressive behavior of such tumor.
Okay, thank you very much. cycles. Someone may help us with advice recommendation.
In Ain Shams University, we now use the haloxane decarbazine.
I'm talking about the shortage.
Adriamycin decarbazine instead of haloxane.
Okay. The other option, sorry for that. The other option, if you just give one cycle and you have shortage of drug, you can shift to another regimen like taxotere-gemzar. I think it's also reasonable, very reasonable one, and the response rate is little higher than the adriamycin haloxane.
Any other comments from the group?
No, go ahead, Dr. Ahmed. No.
Thank you for your attention. I'm sorry to be very with you.
Thank you very much, Dr. Ahmed, and thank you for your efforts for the Egyptian network for sarcoma. And I would like also to thank Dr. Mohammed Al-Kilani and Dr. Raham for the invitation and for this really organized session. And the floor is open if any questions for the 3 lectures or any suggestions, or anyone wants to join the Egyptian network, so we could communicate today and have this collaboration effective from any universities. I mean, Dr. Karim.
Maybe I have a question to Dr. Ahmed Ramadan. So when do you often consider single agent versus versus doublet chemotherapy? I mean, there is many guidelines offering that you can go for a single agent. Perhaps if you see your patient is a bit frail, or you see that is really you do have like a long disease-free interval, then you can go for a single agent. But I think for your patient, yeah, it did have a short relapse, so this is why you offered maybe a doublet chemo. So in my institute in Qasr Aini, we often go for single agent adriamycin in these cases. Thank you.
I think the rate of response is the difference. If we want a rapid rate of response, we will use doublet chemotherapy. And if we don't want a rapid response, we can have single. Also, performance of the patient is important. ECOG performance due to toxicity of regimens of chemotherapy we use.
Okay. So I think, I mean, by this we have to thank the organizers. Again, thank Dr. Mohammed Al-Kilani, Dr. Raham for the excellent organization of this sarcoma session, and we close the session. Thank you very much.